Let's just go through some general information for CNS cancers. First, anatomy. The end of the cord or the conus medullaris in adults is higher up than it is for children. So for adults, it's L1 to L2, and the end of the cord in newborns is L3 to L4. The termination of the thecal sac is S2. You can remember that sac for S, sacrum, S2. CSF flow, the pattern starts in the lateral ventricle, is labeled 1 here. It then flows medially into the so between ventricular foramen of Monro. It then goes to the third ventricle located here. From the third ventricle, it goes down to the cerebral aqueduct, and then to the fourth ventricle, this triangle-shaped area here, then either the foramen of Luschka laterally or the foramen of Magendie medially. So one more time, lateral ventricle, interventricular foramen of Monro, third ventricle, cerebral aqueduct of Sylvius, fourth ventricle, foramen of Luschka, or foramen of Magendie medially. The contents of the cavernous sinus are frequently tested. It's cranial nerves 3, 4, V1, V2, and 6. 6 is usually the first damaged. The easy way to remember this is it's cranial nerves 3 through 6, just V3 is missing. NF1 is associated with optic gliomas and astrocytomas. NF2 has schwannomas, multiple meningiomas, astrocytomas, and ependymomas. Grading, this is not so much done anymore, but just be aware of it. Amen. For nuclear atypia, mitotic index, endothelial proliferation, and necrosis. You need all 4 for GBM, 2 out of 4 for anaplastic astro or astro-oligodendroglioma, a quarter for low-grade gliomas. MSR equals maximum safe resection. MRI, T1 is the longitudinal relaxation images. 1 looks like L in longitudinal, so just remember T1, longitudinal relaxation. This is good for soft tissue. T2 is a transverse relaxation image. This is good for fluid. So again, T1, longitudinal, I looks like an L, good for soft tissue. T2, transverse, good for fluid. FLAIR is fluid attenuated inversion recovery. Fluid attenuated inversion recovery, FLAIR. This is T2 with the CSF signal subtracted out. MRI spectroscopy. NAA is a neuronal marker. Choline looks at cellular integrity. Creatinine looks at cell energy, and lactate looks at anaerobic metabolism. Tumors have increased choline on MRI SPECT, but decreased creatinine and decreased NAA. Tumor necrosis will show decreased choline and increased lactate with decreased creatinine and NAA. Abscess will show restricted diffusion. Differential diagnoses, supratentorial lesions, you can remember by COP-GEM for suprasellar. COP-GEM, craniopharyngioma, optic glioma, pituitary adenoma, germ cell tumor, usually of the third ventricle, ependymoma, and meningioma. Again, supratentorial, suprasellar lesions are COP-GEM. Remember this as craniopharyngioma, optic glioma, pituitary adenoma, germ cell tumor, ependymoma, or meningioma. Then we go down to the central thalamic pineal regions. Remember GG, PPM, germ cell, glioma, pineocytoma, pineoblastoma, and METS. For cerebral and peripheral, MOGLOV, METS, astrocytoma, glioma, lymphoma, abscess, vascular. So again, suprasellar COP-GEM, central GGPPM, cerebral, peripheral is MOGLOV. Infratentorial differential, posterior fossa is GEM-JAMA. You can remember this as medulloblastoma, ependymoma, glioma, JPA, cerebellar astrocytoma, METS, and ATRT. Brainstem, GAEA, glioma, AVM, encephalitis, or abscess. Craniospinal irradiation is done for medullos, for supratentorial PNETs, for pineoblastoma and non-seminomatous germ cell tumors. CSI M positive only for germinoma, ependymoma, and atypical teratoid rhabdoid tumor. Moving now to malignant high-grade gliomas. GBM is grade 4. Classically, this is shown to have pleomorphic nuclei or atypia, increased mitotic rate, microvascular endothelial proliferation, and pseudopalisading necrosis. Differential diagnosis includes other gliomas, which are low or high grade, metastases, lymphoma, infection, or demyelinating diseases. The WHO 2021 molecular classification now just basically looks at IDH status primarily. So is it IDH 1 or 2 mutant or IDH wild type? If it's an IDH wild type tumor, then it is automatically classified as being a GBM. You then look at EGFR amplification or TERT positivity, chromosome 7 gain or 10 loss. Diffuse astrocytic glioma is an IDH wild type with molecular features of a GBM. Either, again, EGFR amplification or plus 7, minus 10 whole chromosome gain or loss or TERT promoter mutation. For an IDH mutant, grade 2 or 4 astrocytoma, CDK2N2A homozygous deletion is automatically considered a grade 4 glioma. Workup, H&P, ask about onset, duration, acuity, chronicity of symptoms. Headache, nausea, vomiting, focal neurologic deficits, and seizure are the most common presenting symptoms. Physical exam, you should have a complete neurologic exam, a cerebellar exam with a fundoscopic exam, and assess colonoscopy performance status. Labs, you should get a CBC and a CMP. Imaging, you want an MRI brain and a CT head. CT chest, abdomen, pelvis, if there's suggestion of metastatic disease. In terms of neurosurgery consult, maximal safe resection is the goal. Obviously, more resection equals better survival. If not, then biopsy. Pathology, again, IDH mutant is rare and usually denotes a secondary GBM transformed from a low-grade glioma. MGMT equals a DNA repair enzyme. If it's methylated, you have decreased MGMT and increased response to TMZ. It's an alkylating agent because decreased repair. In terms of post-op MRI, you want 48 to 72 hours after surgery. New NRG RPA, cranial mets, age less than 50, MGMT level. TMZ alkylating agent that methylates DNA, interfering with replication. Cells that express MGMT can reverse this methylation damage. Staging, WHO grade 4 GBM. Other pearls, bevacizumab doesn't improve overall survival in the upfront setting. There are mixed results. See quality of life. SRS boost does not improve overall survival in the upfront setting. There's a negative RTOG trial here. Timing of radiation after surgery, there's no evidence that this matters. It's typically 4 to 5 weeks after surgery. For patients who are not elderly, so less than 70 years old, the goal is the STOOP regimen. This consists of maximum safe resection followed by radiation 60 gray, 2 gray of fraction with TMZ 7 days a week, followed by adjuvant temozolomide times 6 cycles starting 1 month after radiation, plus or minus tumor treating fields. The concurrent TMZ dose is lower at 75 milligrams per meter squared per day. The adjuvant dose is higher. In fact, I think it's twice as high. So 150 milligrams per meter squared per day times 5 days every 28 days. Double strength Bactrim 3 times a week for PCP prophylaxis. We can talk about adding tumor treating fields, which are greater than 18 hours a day in the adjuvant setting after chemoradiation. TDF increases median overall survival from 16 months to 20.9 months, so there's a 4-month benefit to it. For elderly patients greater than 70 years old, there are a lot of different regimens. If they have a very high KPS, so good colonoscopy performance status, you can do the STOOP regimen of temozolomide plus radiation 60 gray and 30 fractions. If they have a normal KPS, you can consider temozolomide plus radiation of 40 gray and 15 fractions, which is the Perry trial. If they have a mid KPS, you can do TMZ or a single agent RT. TMZ alone, if they have methylated tumors. If the tumor is not methylated, then you treat with radiation alone, and the dose fractionation schemes are variable. You can do 40 and 15 per ROA, 34 and 10 per Malmstrom, and 25 and 5 per ROA. You could also treat with bevacizumab alone. If the patient has a very poor performance status, then simply use supportive care. For recurrent GBMs, you want to enroll in a clinical trial. Otherwise, bevacizumab, monoclonal antibody to VEGF, 10 milligrams per kilogram every 2 weeks. For reirradiation, typically the dose is 30 to 35 gray and 10 fraction to the contrast enhancement only, plus a 3 millimeter PTV margin. There's retrospective evidence that this may increase overall survival with a median survival of 10 months. RTOG 1205 tested bevacizumab plus or minus this radiation regimen with no difference in overall survival. Evidence, the STOOP trial, which is updated, was looking at the role of radiation plus or minus temozolomide. These patients were all less than 70. They had good performance status with ECOG of 0 to 2. 50% had MGMT methylation. The median survival was increased from 12 months to 15 months with the addition of temozolomide. The overall survival at 5 years was 2% versus 10% with temozolomide. Again, MGMT promoter methylation was the strongest predictor of outcome. For MGMT hypermethylated, the median survival was 15 months versus 23 months. No hypermethylation, median survival 13 months versus 12 months. Temozolomide, 7% grade 3 heme toxicity, platelets, white blood cell count can drop. The next trial is PERI-EORTC 26062. This is looking at the role of treatment of high-grade gliomas in the elderly with the addition of temozolomide to hypofractionated radiation. Though I remember this is Perry's an old money family, also 65 is about dad's age, which is the age cutoff for this. This is about 550 patients. All were 65 years or older and had good performance status, ECOG 0 to 2. They either got 40 gray and 15 fractions plus concurrent and adjuvant Temodar versus radiation alone with the same fractionation scheme, 40 gray and 15 fractions. The median overall survival here was 9.3 months with temozolomide versus 7.6 months, and progression-free survival was 5.3 months versus 3.9 months. Again, improved with temozolomide. The bottom line from this trial is that conventional radiation for GBM is too harsh for patients that are 65 years and older, but the addition of temozolomide to hypofractionated radiation in this age group does improve overall survival compared to short course radiation alone. So again, PERI-EORTC 26062, high-grade glioma in the elderly, the addition of temozolomide to hypofractionation, all 65 years or older, ECOG 0 to 2, looking at 40 and 15 fractions with concurrent and adjuvant Temodar versus 40 and 15 alone. Overall survival is improved by about 2 months and progression-free survival by about 2 months with the addition of Temodar. The EF14 trial from STOOP is looking at the role of tumor-treating fields and the benefit. All of these patients received radiation and concurrent Temodar, then were randomized to either adjuvant Temodar and TTF until progression or 2 years versus adjuvant Temodar alone. Again, tumor-treating fields are low intensity, 200 kilohertz frequency alternating electric fields that are delivered greater than or equal to 18 hours a day via 4 transducer arrays on the shaved scalp and connected to a portable device. It impairs cell division via inhibiting microtubule assembly. The median overall survival with tumor treating fields is 21 months versus 16 months without, so there's a 5-month median overall survival benefit. The benefit of TTF is present in any MGMT status in any age, but it is greatest in MGMT methylated tumors. Over half of these patients, 52%, had a grade 1 to 2 skin reaction, and you need to wear the actual scalp electrodes for greater than 50% of the time to have any benefit. GBM trials for the elderly, ROA, IAEA, Malmstrom. ROA looked at the role of 60 and 30 versus 45 and 15, found no overall survival difference. Malmstrom is looking at GBM in 60 years or older. These patients got TMZ alone, 34 and 10 fractions or 60 and 30 fractions. There was inferior survival in the 60 gray versus 34 gray group. So the higher dose with Malmstrom actually caused worse survival. IAEA is looking at 98 elderly and or frail patients. Frail was either age 50 or older and KPS 50 to 70. Elderly and frail was age 65 or older and KPS 50 to 70%. Elderly was simply age greater than 65 and KPS 80 to 100%. IAEA randomized to 25 and 5 versus 40 and 15 and found no difference in overall survival, progression-free survival, or quality of life. In terms of techniques and planning, SIM, you want to do CT, SIM with MRI. Again, T1 post-contrast and T2 flare. Both are going to be post-op with a mask, Aquaplast mask. Volumes and dose, RTOG volumes for standard fractionation. You do 46 in 2 gray per fraction and then boost by 14 gray. CTV 46 is the cavity plus T1 enhancing residual contrast plus T2 flare plus 2 centimeters. You crop it from the bone, falx, tentorium, and ventricles. If there's no edema, then you simply take the cavity plus the enhancement with the contrast and add 2.5 centimeters to get your CTV 46. Your CTV 60 is the cavity plus T1 enhancing residual plus 2 centimeters, again cropped from bone, falx, tentorium, and ventricles. It makes sense that the actual cavity, not just the surrounding edema, gets 60 gray. It's a smaller volume, and it's really what we're most concerned about. The PTV is a 5 millimeter expansion on the CTVs. Again, if no edema is noted, the T1 contrast enhancement cavity gets 2.5 centimeters to 46 gray, and then the T1 contrast cavity gets 2 centimeters to 60 gray. EORTC volumes for standard fractionation simply looks at the T1 contrast cavity plus 2 centimeters to 60 gray. EORTC volumes for hypofractionation, 40 and 15 fractions. CTV 40 is the cavity plus T1 enhancing residual plus 1.5 centimeters, cropped as above. And then PTV 40 is simply a 5 millimeter expansion on that. Planning, use IMRT with 5 non-coplanar beams or VMAT. If you're using IMRT, avoid beams through the mouth or the lenses. Coverage, PTV greater than 95% of the volume receives 100% of the dose. Alternatively, 95% of the volume gets 95% of the dose. Max dose should be less than 107%. OARs for standard fractionation, cord should get less than 50, brainstem should get less than 55, optic chiasm and nerves less than 55, retina less than 45, lens less than 7 gray. Hypofractionation per the Perry regimen, which again is 40 and 15. Heterogeneity within 5%, so hot spot should be less than 105, cold spot should be greater than 95% is what that means. Optic nerve, chiasm, globes, brainstem, no more than 100% of the prescribed dose. Lenses should get less than 4 gray. In terms of coverage, constraints, coverage, we've already covered. Toxicity and follow-up, Stoop MGMT methylated median survival is 24 months. MGMT non-methylated median survival is 12 months, so it's half of the methylated status. Peri-EORTC, MGMT methylated median survival is 14 months. MGMT non-methylated median survival is 10 months. TMZ alone, 8 months. RT alone, 5 months. Median survival, 10 months after occurrence. If treatment with reirradiation or bevacizumab. Toxicity, fatigue, 25%, moderate to severe. Temodar decreases platelets, so you check labs every 2 weeks. Follow-up, you want an MRI 1 month after radiation, then every 2 months for 3 years, then every 6 months after 3 years. RANO criteria in follow-up to determine if the patient's had a complete response, a partial response, stable disease, or progressive disease. Radiographic progression occurs on the first MRI in 50%, usually within 3 months. Higher rates in MGMT methylated tumors. Half are true progression, half are pseudoprogression. Do not change the treatment after the first scan. Pseudoprogression stabilizes or improves within 3 months of the end of treatment. In terms of actually identifying what some of these changes look like on imaging. So again, these are the RANO response criteria, looking at T1 gadolinium, T2 flare, new lesions, role of steroids, clinical status, requirement for response. Pseudoprogression, post-therapeutic progressive and enhancing lesions on MRI, noted after completion of treatment, which are not related to tumor progression, but are related to treatment effects. This just shows gliomatosis cerebri with mass effect and thickening of the anterior commissure and corpus callosum. This is not operable, and this would have to be treated differently.